Hi, everyone. On behalf of the National Eczema Association, I'd like to welcome you to our Webinar Wednesday presentation, About Face, Managing Facial Eczema with Dr. Vivian Shi. I'm Sarah Harris. I'm a writer with eczema. I run the site skinstories.us, where I share stories of people with chronic skin conditions living full lives. Before we get started, I want to encourage you to join Nia and the entire eczema community in celebrating Eczema Awareness Month this October. You can find out how to get involved at eczemamonth.org. Okay, without further ado, let's get our presentation started. We'd like to thank our 2019 Webinar Wednesday sponsor, Sanofi Genzyme and Regeneron, whose unrestricted educational grant has made today's presentation possible. Our presenter today is Dr. Vivian Shi. She's a board-certified dermatologist and serves as an assistant professor of dermatology at the University of Arizona College of Medicine in Tucson. She also directs their eczema specialty clinic and the Inflammatory Skin Research Fellowship Program. And with that, I'm pleased to introduce our presenter, Dr. Vivian Shi.
Hello, everyone. It's a pleasure to be here. Thank you for having me, Nia. I'm very excited to present this topic today, and it's one of my favorites because it's really applicable and salient for eczema patients. Well, here are my conflict of disclosure. I've served as a consultant, investigator, or have received research funding from the following corporations that are unrelated to the content of this presentation. So let us get started. Head and neck eczema is very common in folks with atopic dermatitis or eczema. It can be seen in up to 25% of the eczema patients, and it's more common in children. And literally every part of the face can be affected by eczema, from eyes, the nose, the cheeks, around the eyes, and even the neck. So why do we get head and neck eczema? A big part of it is environmental exposure because our face and neck are exposed to the elements very commonly. And pollutions in the air can contribute to eczema, as well as allergens and irritants that comes off the original surface. Believe it or not, topical medications and products that we use to treat eczema can also cause eczema. The face has a very immature skin barrier. This is especially true in children. There are a number of drug-related eczema as well on the face, and a ton of mimickers of the classic eczema or atopic dermatitis. And when a person has head and neck eczema, it really has a heavy social burden and interferes with our confidence and our social interaction. So it's more important that we diagnose and treat appropriately when a person comes in with eczema on the face and neck. So eczema has a different distribution anatomically according to the person's age. When we're an infant, eczema is more heavily presented on our face, our neck, and outside of our skin, such as the outer arms and outer legs. As we become older in childhood and also in adulthood, the eczema kind of migrates from the original sites to involve more of the skin folds, such as the inside of the elbow, back of the knees, and also in front of the ankles. But what's been really puzzling for a lot of folks is, why do little kids, infants, always get eczema on the face even when every other area is pretty mild? Turns out it has a lot to do with filaggrin, which is a protein that our skin makes. So when our skin makes filaggrin, it's this really big size protein, then our body uses an enzyme to cut them into small pieces, and these form the natural moisturizing factor of our skin, or MMF. Now, MMS is very important to, has a very important function in our skin barrier. It sits in the skin cells and attracts water, and so the cells swell up and sit tightly together to help our skin get moisturized. So why do we get eczema on the cheeks as a child and they're more stubborn to go away? Turns out the cheek skin is slow to mature with respect to the natural moisturizing factor levels and the skin cell maturity. So if you take a look at this image here, as the color of blue gets darker, it means skin maturity. And compared to other part of the face, such as the nose, the cheek is very slow to mature in terms of skin barrier maturity. And it only reaches steady state at about age 7, so school age. This can partially explain why we don't really grow out of our eczema until school age. And that's especially true on the face. Let's take a closer dive at the other anatomical areas that can be affected by eczema on the head and neck region, one of which is the ear. And on the left side, you can see that this patient has chronic ear itching to the point where there has grown little scars and thickened tissue on the earlobe. And there can be fissuring and cracks and draining on the back of the ears as well. And ear involvement of eczema tend to be a marker for severe itch. And so when I see a patient comes in with very severe ear eczema and fissuring, that's a sign telling me that we need to treat this eczema more aggressively because the patient's really suffering. Eczema can affect the neck, especially the neck folds. And when eczema is very itchy, when we scratch, the skin actually produces a protein called the amyloid and deposits on the skin surface. And you can see it on the picture on the right here, it forms kind of this dirty neck appearance. And this is called macular amyloidosis. And that comes from chronic itching and scratching. Eczema can also affect the lips. Now, this picture shows a condition called atopic cheilitis. Cheilitis is another term to describe inflammation of the lip. You can see this person has inflammation on the lip. There's blurring of the border of the pink lip and the skin. There's cracks and fissuring, and this is very painful. We can also get angular cheilitis. Angular means the corner of the mouth, and so you can see the fissuring at the corner of the mouth. This is very common in small children when saliva and food residue sits on the corner of the mouth to cause eczema. We also can get lip licorice dermatitis. You can see that eczema skin is very dry, so some of our children actually forms a habit of licking the lips. You can see this picture kind of forms a ring that corresponds to the shape of the lip. We can also get eczema around the eyes. And when the eyelids are inflamed, it's a term called blepharitis. You can see that there's severe swelling and inflammation around the eyelids. There's also a term called conjunctivitis, inflammation of conjunctiva. Now, the conjunctiva is the lining of the eye, and we have two sets of conjunctiva. One set is called the palpebral conjunctiva, which kind of sits in the inner surface of our eyelid. There's also bulbar conjunctiva, which kind of sits on the eye. And folks with eczema can have atopic conjunctivitis, and up to 60% of them will get that. So it's important that we realize conjunctivitis as being one of the complications of eczema and refer and treat appropriately early on. Folks with eczema can get this phenomenon called the Denny Morgan folds, and these are wrinkling and darkened color on the lower eyelids. This can occur even when there's no active eczema around the eyes, and it's one of the hallmarks of eczema. This is a patient of mine who has graciously allowed me to share the photo in teaching. He has very severe eczema together also with conjunctivitis. His eyes are always red. You can see that he's got swelling of the eyelids from eczema called the blepharitis. And he also has Denny Morgan lines, which are these wrinkles and darkened folds in the lower eyelids. In addition to eyelid involvement, the inside of our eyes can also get affected when we have eczema. Eczema folks tend to have a condition called keratoconus. This can be seen up to 10% of adults with eczema. And our cornea is this clear shaped lens in front of our eyes, and that helps to change shape and focus the light that we see to give us visual acuity. And when we have eczema, we can get keratoconic cornea, in which the cornea bulges out and thins out. And as you can see, when the cornea changes the shape, it has difficulty focusing light, so we can get blurry vision. So it's important that we refer very severe eczema patients to an ophthalmologist early on, because keratoconus can be partially corrected by corrective contact lenses. Eyelid eczema is very common in folks with atopic dermatitis. Up to 70% of them who have recurrent eyelid involvement may have a component of allergic contact dermatitis. That is when a chemical comes into contact with the eyelid to trigger inflammation. And our eyelid is one of the thinnest parts of the skin. So whenever we get the defect in our skin barrier, these allergens and irritants tend to penetrate more to cause issues. And so when I see a patient with recurrent eyelid dermatitis, I will consider referring them to patch testing. Now, patch testing, as you can see here in the photo, is a way for us to diagnose which allergens that can be contributing to allergic contact dermatitis. Essentially, we put these sticky pads that contain different wells, which contains the allergens that we most commonly encounter on the back of a patient. They will come back subsequently to get the patches peeled off, and we, as a dermatologist, will read the reaction as shown here on the bottom to diagnose allergic contact dermatitis and also their severity. So the photo here is a mild reaction of allergic contact dermatitis. The one in the middle is a moderate reaction, and the one on the right is a severe reaction. So I wanted to bring you to the next part of my presentation, is recognizing what are some of the mimickers of head and neck eczema. So if you take a look at this collage here, all of these patients have some involvement of inflammation of their skin on the head and neck, but not all of them are eczema. So we'll walk through each one of them one by one. There are a lot of mimickers. This photo here on the right is actually the buff-tip moth. It's the master of masquerade. It can be found all across Europe, all the way to in Asia and Eastern Siberia. So the mimickers of eczema include airborne contact dermatitis, sweat contact allergy, Keratosis pilaris, Peri-orificial dermatitis, steroid-induced rosacea, Demodex mite overgrowth, Malassezia yeast hypersensitivity, irritation from food and saliva, even from Dupilumab-Associated. Dupilumab is a medication that we use to treat moderate to severe eczema, which we'll talk about in a little bit. So let's dive in. Keratosis pilaris is very common in folks with atopic dermatitis, but also in folks that are healthy. Up to 50% of the general population will have keratosis pilaris. But when we see keratosis pilaris on the face, it's commonly occurring in conjunction with facial eczema. So what is keratosis pilaris? So if you see that this is an illustration of the normal skin, we have hair follicles, that there's an opening of the hair follicle orifice on the skin surface. And keratosis pilaris happens when the protein within the hair follicle is producing abnormally that forms a keratin protein plug on the skin surface. It's almost like an ingrown hair, and it can be sometimes quite itchy and exacerbate pre-existing eczema. Folks with eczema can get a true allergy to their sweat, and this is because they may have a hypersensitivity reaction to the yeast protein that gets let out onto the skin surface from the sweat glands. And this can cause hives, redness, swelling, and intense itching, and it worsens existing eczema on the head and neck area. Although it's hard to predict when we'll sweat, but before physical activity or when the temperature goes up, it may be beneficial to take some oral antihistamines before predictable sweating to decrease this allergic response and hive formation. We can get airborne dermatitis. This can be caused by any aerosolized substance, and especially true in windy areas and in desert where I reside. So some of the aerosolized substances include fragrance, our aromatherapy, especially with essential oil. This is becoming more popular, but essential oil aromatherapy has been shown to worsen atopic dermatitis. Next is environmental pollution and dust. You can see that this is a photo of Arizona during our dust storm. It blows up everything in the desert and really has been shown to worsen eczema. Other aerosolized substances can worsen eczema include topical drugs and moisturizers, certain plants such as pollen. This is a picture of a tree that is common in Arizona. Called the Palo Verde tree. And in the springtime, the entire tree turns into this big tree, bloom of yellow pollen. And when the wind blows, the entire neighborhood can have a yellow color in the air. In some areas, there's also fungal spore that can be on the ground that gets blown into the air. And a common fungus that produces spore is called aspergillus. There can be also household dust mites and pet dandruff that can be aerosolized to worsen eczema. And in patients who also have asthma, they're at a higher risk of getting airborne dermatitis too. This is a patient who also graciously agreed to share her photo for teaching. She has airborne contact dermatitis, and normally her eczema is really well controlled with minimal head and neck involvement. And one day she went biking on a river trail, and it's been a very windy and dusty day, and she came into the clinic a couple days later with this rash that's new. You can see that she gets this ill-defined redness all over her face, but interestingly, there's a sparing of eczema just below the chin, and then there's neck involvement as well. And you can see that the sparing of the area below the chin is very classic for airborne contact dermatitis because our chin protects the allergens from hitting that part of the neck. And so this is a clue that we sometimes use as dermatologists to diagnose airborne contact dermatitis. Another entity that can mimic facial eczema is peri-orificial dermatitis. And orificial means opening, and peri-orificial dermatitis means eczema happening around the opening of our body. And this condition can occur around the eyes, around the nose, and around the mouth. These come in these pink little bumps and sometimes pustules in this location. And that can be sometimes associated with overuse of topical steroids. A similar entity to peri-orificial dermatitis is steroid-induced rosacea. And as the term tells you, it can be caused by long-term topical steroid use. We will get this ill-defined redness of the face, focusing on the cheeks, the nose, and the chin. And you can also sometimes get red pus bumps too. So what do we do if we suspect the patient has peri-orificial dermatitis or steroid-induced rosacea on top of classic eczema? First, we want to know the risk factors. Female are more likely to get these two conditions, especially if they have a history of eczema or asthma or recent topical steroid or inhaled corticosteroid use. And the mainstay management for these two conditions is slowly tapered topical corticosteroids. A rough stopping of the topical steroid can cause a rebound and acute flare of their eczema. We want to switch from topical steroids to a non-steroid anti-inflammatory medication. These topical medications can include tacrolimus or pimecrolimus. Sometimes we'll use topical anti-mite medications because steroid-induced rosacea can sometimes be associated with mite, causing inflammation on the skin, and these mites normally live in our skin. And some modalities include topical metronidazole, which is the antibiotic cream, topical ivermectin, which is an anti-mite medicine, and some other anti-inflammatory medicines that are used topically include topical sulfacetamide, which has antimicrobial and anti-inflammatory medication properties, and topical azelaic acid. When these two conditions between moderate to severe and cannot be controlled with topical modalities and stopping corticosteroids, we will sometimes use a short course of oral antibiotics, such as doxycycline or erythromycin. So we briefly mentioned about mites. Why do we have mites in our body? Well, that's just who we are. We actually have a lot of microbiome in our skin, yeast, bacteria, viruses, and even mites. And we now know Demodex mites that live in our hair follicles and oil glands, as shown here on the right, can release toxins to stimulate inflammation. And these toxins can stimulate the release of a pro-inflammatory molecule called the IL-17, which causes eczema flare. And these mites love skin with high pH or basic pH and low moisturizer. And the classic skin that they love is eczema skin, because eczema skin is more basic and has low moisture or drier than healthy skin. This is more photos of Demodex-induced eczema on the face or inflammation of the face. You can see this young woman with ill-defined redness and bumps and pustules on the cheek and the chin, and this young gentleman also in a similar distribution. And if we suspect a patient with mite overgrowth, we can actually use a small blade to scrape off the pus bumps and look at the microscope, and what we will see are these little mites under the microscope, and they also have eggs too. Yes, we all have this in our skin. Another mimicker of facial eczema is Malassezia dermatitis. Malassezia is a yeast that normally lives in our skin, and in some individuals, especially in folks who are more greasy and live in warm and moist climates, they can be overgrown. And yeast actually uses our oil production as nutrient. And so they love greasy areas such as the face and the chest of our body. Malassezia dermatitis tend to worsen during teens and in young adulthood when our sex hormones surge and we become more oily in our skin. And eczema patients are more likely to mount an immune response to these Malassezia yeast proteins to cause flaring of their eczema. Typically, this dermatitis will have unsatisfactory response to the conventional anti-inflammatory medication, such as the corticosteroids or pimecrolimus and tacrolimus. And unfortunately, there is no reliable skin or blood testing for Malassezia dermatitis. The diagnosis is basically on clinical suspicion. And in order to treat this, we will need to use topical and sometimes oral antifungal medications. This is a published case report of a patient with Malassezia dermatitis with a background of atopic dermatitis. When he was younger, you can see the photo here that his eczema is relatively well controlled, but when he gone through puberty, his eczema really flared with eczema around the eyes, around the nose, and on the chin. This is how he looked like after he was treated. And he actually required oral antifungals in order for his eczema flare to improve, which tells us that this is a fungal-induced dermatitis on top of atopic dermatitis. So how does Malassezia yeast worsen atopic dermatitis? This is a diagram that I love very much that illustrates the cause. So in eczema individuals, the skin barrier is already defective. It's got leaky skin. So the Malassezia yeast that normally lives in the skin can penetrate deeper into the deeper part of the skin called the dermis. And the immune system is already overactive in eczema individuals. Coupled with the Malassezia protein, it causes the inflammation in the deeper skin to worsen its existing eczema. The medication that we use to treat moderate to severe eczema, Dupilumab, can also be associated with some ill-defined and non-specific rash on the face. This is a published case report of a young woman who has moderate to severe eczema and is treated with Dupilumab. And every time when she gets her Dupilumab injection every other week, within hours, she'll develop this ill-defined itchy red rash on the face and on the neck that will resolve spontaneously after a few hours. We don't exactly know what this Dupilumab-associated rash is yet. We need more research to find out. This is another case of my patients who were on Dupilumab. They can develop a rosacea-like rash with injection, with redness and some pus bumps on the cheeks and on the nose. A separate patient of mine who has previously not had eyelid dermatitis developed recurrent eyelid dermatitis with Dupilumab injection. So we really need more research to understand why this non-specific rash comes up with Dupilumab treatment. But there are some theories on why that is. Dupilumab is a medication that blocks a specific arm of overactive inflammatory pathway in eczema individuals, namely interleukin-4. And interleukin-4 is within a special pathway called the Th2 pathway. So if we were to block off this pathway over here, so we theorize that the immune inflammation may be redirected alternatively to these other pathways to cause inflammation, such as rash and rosacea and overgrowth of the microbes. So this is kind of a summary slide looking at the various mimickers of eczema that we just talked about. So we have the allergic contact dermatitis here with ill-defined redness and peeling, mainly around the eyelids. We have the rosacea-induced, steroid-induced rosacea with red bumps and ill-defined redness around the middle of the cheek, the nose, and the chin. And we also have peri-orificial dermatitis here with red bumps and pus bumps around the orifices of our skin, around the eyes, around the nose, and around the mouth. And with the Malassezia head and neck dermatitis, we get this ill-defined eczema and pus bumps in oily areas such as the forehead, the middle of the face, the chin, and the neck, and sometimes even on the chest too. Last but not least, with the mite-induced or Demodex-induced dermatitis, we get puffs, bumps in the center of the face as well. So you can see that it's not always easy to diagnose head and neck eczema, and the mimickers can look very similar to each other. So what are some of the practical tips? What are some of the things we can do at home to minimize head and neck eczema flare and also development of some of the mimickers of our eczema? So folks with asthma, after they use the inhaler or nebulizer treatment, it's important to wipe off the face and the neck afterwards. We should quickly rinse off the sweat after exercising, then moisturize. And we should use a soft cotton towel, and we may even use a non-drowsy antihistamine just an hour before anticipated sweating. We should avoid commercial wet wipes or baby wipes because oftentimes they can contain preservatives that are allergens to eczema skin. We should also apply a barrier cream around the mouth before eating and after wiping. This is especially true in young children. And some of these barrier creams include Vaseline, wax oils, or zinc oxide. Now, zinc oxide is a component in diaper rash cream also. We talked about wiping off the food residue just right after eating to prevent the residue from sitting on the skin and cause irritation, and also wiping off the excess saliva too. The face and the neck tend to be more prone to itching and burning and flushing. This is because of a notion called the neurogenic inflammation. Essentially, this term means heat causes skin flushing, swelling, and inflammation, itch. So what we find is that various triggers from the environment will enter the defective skin and actually causes the skin nerves to release mediators to tell the nervous system to sense itching and burning. The nervous system also sends signal back to the blood vessels to tell the blood vessels to dilate and get engorged, and which in turn causes flushing and redness. And this process further makes more inflammatory proteins and molecules to release onto the skin to cause itching. So you can see this is really a vicious cycle that we need to break. The skin also has a circadian rhythm. Previously, we thought that folks are just more itchy at night because things are quiet and there's no stimulation, so we think of itch some more. But more recently, studies have shown that skin actually has a circadian rhythm, and we're itchy and more inflamed at night for various reasons. At night, the skin barrier function, as shown here, is most effective, and the oil production is also the lowest at night. Not only that, the pro-inflammatory cells are most active at night, and anti-inflammatory properties are lowest at night. Coupled with that is instability of the blood flow in the skin at night. So together, this adds to defective barrier at night, a lot of itching, a lot of inflammation, and a lot of flushing and redness, which tells us that we should be proactive in treating eczema in preparation to the nighttime flare. So we should use topical medications early in the evening or late in the afternoon to prevent nighttime flare and nighttime itch. So nighttime itch is difficult to control, but I'm going to give you some practical tips to improve them. Remember the neurogenic itch where heat can increase flushing and itching? Well, we can combat this by using a cooling pillow. This is commercially available in many stores and on the internet also. It has a cooling gel that soothes the head and neck area. And some smaller pillows even fit into the refrigerator, and putting it in the refrigerator can further the cooling and soothing effect. You can also get cooling mask to help soothe the inflammation. And you can get one that covers the whole face or just around the eyes area. And they even have the ones with animated or cartoon characters that kids love to use. Cooling spray, cooling water spray is also a good tip because spraying the water mist on the skin that is cooling can calm inflammation and temporarily decrease itch. It's especially helpful if we use cool water also. Another trick that I like to recommend is rice starch mask. This is a cool little trick. Rice has anti-oxidative and anti-inflammatory properties. And in Asia, rice paper mask has been used for many, many decades and maybe even centuries to help soothe the skin. So how do we do this at home, right? You can definitely buy this commercially, but they're quite expensive and may have preservatives that we want to avoid when we have eczema. So this is what I tell my patients to do. It's do it yourself, DIY rice paper mask. You can find these dry rice papers in a lot of the fusion supermarkets. Whole Foods has it, and some of the Asian supermarkets have it too. So when you take it out, there are these dry round sheets. And I recommend cutting them into little pieces that correspond to the various quadrants of our face. So you can get one for the forehead, a couple on the cheeks, a small one on the nose, and a bigger one on the bottom part of the face and the chin. So what you do is you get a little container filled with warm water, then you dip the different, the rice paper into it, and instantaneously it will turn into this gelatinous sheet. And you can apply moisturizers or topical medications onto the face, then put the rice paper mask on, just like this. And it's very soothing, and it's time for relaxation. And the rice paper also helps penetration of our moisturizers and topical medications. Now, depending on where you live, it may dry up after 10, 15 minutes or so. In Arizona, it dries up after 5 to 10 minutes. So you can definitely use some warm water to rehydrate the rice water while it's on the face. And I typically have my patients do it about 30 minutes or so each time, and you can do this every day if you wanted to. So I wanted to thank you for all of your attention and the opportunity for me to share this facial eczema webinar. And this is my dog. Her name is Bubbles, and she is an eczema cheerleader. And she's been cheering me on as an eczema provider and eczema patients too. And I'm leaving you with my referral information here from my eczema clinic. Thank you all for your attention.
Thank you, Dr. Shi. That was so educational and informative. And Bubbles is a super cute dog.
Thank you.
We now have some questions from our community that I bet you have some interesting answers to. The first question is, what kind of makeup can I use that won't trigger a flare-up?
This is a really good question. I love it. I get asked this a lot. There is no one makeup that's perfect for eczema. What may be a soothing and compatible makeup for one person with eczema may be a total allergen and eczema trigger for the other person. As a general rule, there are hypoallergenic makeups available over the counter. But that being said, some of the hypoallergenic claims products can also contain allergens. So it's important to look at the back of the ingredients and discuss with your dermatologist to come up with the best product for you. But as a general rule, if you're going to buy a hypoallergenic makeup, test it in a non-sensitive area of the body first. So, we want to avoid using it all over the face as a first try. So the anatomical area that I typically recommend is in the inner arms. So apply a small dab of the makeup into the inner arm, and do that on a daily basis as you would on the face. Wait a week to see if you get any reaction from it or irritation from it before starting it on the face. And as a general rule, typically for eczema skin, because it's drier, creamier makeups may be more helpful, and try to avoid the ones that are airbrushing makeups. Basically, you put the makeup into an airbrush and you spray onto the face. Some of this airbrush makeup can include alcohol and preservatives and other chemicals to help make it aerosolized. That's kind of the general rule. Try it first in a different area before you do it on the face.
Great. Our next question is about getting professional facials. What recommendations do you have for getting professional facials? The asker says there's so many options for facials. I'm scared I'll get a reaction, or that I won't be able to tell what my true skin type is because my skin is so prone to eczema.
This is also a very common question. Thank you for asking this question. I guess the term here is, what is really a professional facial, right? Many folks will claim them being professionals, but most facials are geared towards acne-prone skin or have anti-aging properties. Unfortunately, both acne facial and anti-aging facials contain products that are very harsh and are difficult to tolerate for eczema patients. Some of these include like chemical peels, like glycolic acid, and also dermabrasion. These are some things we should avoid when we have eczema and sensitive skin, because the skin barrier is already damaged, and using these products and modalities can further damage the skin barrier, making it more leaky. And so allergens, irritants, and infection can go in and cause more inflammation. An eczema facial can be done at home, and it may be the safest way to do this. Typically, an eczema facial should focus on relaxation, moisturization, and also massage. So some of the natural oils that are compatible for most eczema patients may be sunflower seed oil or coconut oil, and moisturization in addition to the oil can be not an aromatherapy, but using a mist machine, using just regular water to help moisturize it. You can also use the rice paper mask that we just talked about. But going to a professional facial salon can be a little risky. But if that's what you would do ask what products are used and in what sequence, and avoid exfoliation and chemical peels. And it's not uncommon that my patients will bring their own eczema kit and eczema products when they get a professional facial outside in a salon.
That's a great answer. Thank you so much. Our next question is about scalp eczema. What can we do for it? Is there a shampoo or something else that you recommend?
Yeah, scalp eczema is tricky. I think the most important thing is to really figure out whether it's true eczema or there's mimickers of eczema on the scalp. Typically, if one were to have scalp eczema, one will have eczema elsewhere in the body. The scalp is one of the greasiest parts of the body, and our own natural oil or sebum is a moisturizing factor. So if you only have eczema on the scalp, I will think twice to see if that's the right diagnosis, because dandruff or psoriasis or seborrheic psoriasis can affect the scalp and can look like eczema with skin inflammation, redness, and a lot of flaking. But if this is true eczema, there's a number of things that we can do. There are topical corticosteroids that are leave-on with more of an oil base that's more soothing. There's also corticosteroid shampoos, such as clobetasol shampoos, that may be helpful for the scalp. But if you're going to use commercial shampoos, remember that shampoo should be used only for the hair, and use it on the scalp. Some of the more gentle shampoos include the eczema there's eczema and psoriasis shampoos that are available. The free and clear shampoo is more gentle, and Burt's Bee also has one that's all natural as well. So just like your topical moisturizers and makeups, you wanted to test on a body, small body surface area first before using on the scalp to prevent getting an allergic reaction in that area. I do want to mention that the brand name that I just discussed is not endorsed by the National Eczema Association. It's based on my personal opinion.
Great, thank you so much. One last question, and you alluded to this a little bit earlier, but I'd love if you could expand on it a bit more. What's the best way to treat facial eczema when you're also dealing with acne? And a lot of the acne products contain ingredients that are much harsher, that are hard for the eczema to handle.
Also a really good question. So going back to just like the previous question, we wanted to make sure that acne is a true diagnosis, because as you see, there are a number of mimickers of eczema, such as steroid-induced rosacea, peri-orificial dermatitis, that can mimic acne too. But true acne must have whiteheads and blackheads. These are your comedones, together with red bumps. So if you only had red bumps without any whiteheads or blackheads, that may not be true mundane day-to-day acne. Luckily though, eczema individuals are drier and less oily, so their acne is less severe. But if they do have acne, their acne treatment must complement their eczema treatment. So typically I will use less harsh acne medication. So instead of doing a higher percentage tretinoin or retinoid product, I will use a lower percentage, or even have them dilute their acne product with a moisturizer so they can tolerate it better. I also recommend doing the acne medication, say in the morning, and then the eczema medication at night, or vice versa, instead of doing it twice a day like a regular non-eczema acne patient. Another tip is with acne medication, start using it every third night first. Use as little as possible. Usually a pea-sized amount is enough for the entire face. And as the skin gets used to the acne medication, you can build up slowly to every other night, then to every night, and watch closely on how the facial eczema changes as you're battling the acne.
All right. Well, Dr. Shi, thank you so much for giving us this great explanation and helping us develop a better understanding of facial eczema. We'd also like to thank Sanofi Genzyme and Regeneron, whose unrestricted educational grant has made today's presentation possible. Everyone who's tuned in, thank you so much for joining us today. You can find tons of additional eczema resources on our website, nationaleczema.org. And on behalf of the National Eczema Association, thank you all so much for attending this webinar. Have a great day.